So my name is Martin. I'm one of the consultants at the Glenfield, and I've been asked to present at some neuro topics here. I realise that we've all got varying experiences of neuro. Please feel free. I haven't got a massive number of slides, and because we're all quite mixed abilities or mixed experiences, feel free to just interrupt or chat or just ask some questions as you go along. So if we start just by looking at the brain is a fatty organ that we all know what it does, but I think it's important to define what it does so we understand how we monitor it when it fails. So feel free to interrupt, but the way I see it is the brain keeps you alive through neuronal and hormonal mechanisms, keeps you awake through consciousness, cognition, and memory, keeps you aware of your surroundings by perceiving your own body and also the surroundings of your body and your sensory organs. And it keeps you able, it controls movement. So when we see a patient who's suffered failure on some level or a global failure of the brain, it's important to just understand what's failed, what functions of the brain are failing to perform, so that we're able to better define and understand the problem. What does the brain need? Any suggestions?
Oxygen.
Oxygen, yeah. It needs perfusion. So in order for the brain to work, it needs perfusion. It receives about 15% of the total cardiac output of perfusion. So clearly it's very dependent. It's a very hungry organ because it doesn't store glucose and it doesn't store oxygen. Therefore, it needs a lot of oxygen. It needs about 50 mils per 100 grams of brain. And of that perfusion that it receives, it's only extracting about 20% of the oxygen that goes through it and 1/10 of the glucose that goes through it. So clearly the body values the brain so highly that that it's going to oversupply the brain for all materials, which is why the brain is actually quite resilient sometimes before it decompensates. And that circulation itself comes from largely anterior circulation. The brain needs to be protected. It's a soft and fatty organ, so it needs chemical protection through the CSF and the chemical mechanisms of the blood-brain barrier, and it needs mechanical protection because it is so vulnerable. And this third one, I was going to call it purification just to go along with the P's, but excretion. It needs to clear its metabolic waste products. So we have to think about the drainage of the brain, both through the CSF and through the vascular drainage. And I think when we're trying to provide care for the brain, I think these are the key things we need to consider. So what's in the head? So a typical cranial vault it's a non-compliant vault. It will contain about 1,600 mils of volume. I say mils instead of kilograms, because I think it's important to realize that actually the brain is taking up 80% of that, with about 1,300 mils of volume inside the head. The CSF is the transcellular fluid that's coming out, and it's also provides a buffered environment. It provides an effective support for the brain. So this fragile and heavy organ that's at the top of the head, its effective weight is reduced from about 1,300 mils to about milligrams to about 40 grams. So it reduces the effective weight, and therefore the susceptibility to traumatic injury is reduced by CSF and blood, which again, both the CSF and the blood together is about a can of Coke, or you could say the CSF is about a glass of wine, in the context of about 500 mils of CSF being produced a day. So you could say you get a bottle of Coke a day of CSF, of which half a can of Coke is in the circulation at any one point in time. And with the blood, again, if you're saying it receives about 15% of cardiac output, you're talking about 1,300 litres a day of blood is flowing through the brain, and at any one time only 150 mils is in the brain. So it's clearly a very active organ, and therefore if you do anything to interrupt or disturb that environment, it can quite rapidly and aggressively deteriorate. How is the brain injured? You have the physiological, so excitotoxicity and seizures, which is commonly seen. You can have infection, autoimmune. In the physiological area, you can also include toxins and drugs, which I forgot to put on the slide. There can be vascular insults, so strokes, so vascular insults, again, you've got to realize that the blood flow through the brain is extremely active, and therefore anything that interrupts that blood supply can quite aggressively change. So you've got arterial thromboembolisms, venous thromboses, and hemorrhage. And then the focus of this talk is more of the structural issues, tumor and trauma. The CT you can see there is a traumatic CT. That CT is a motorcycle rider who had a crash, and the person who was riding on the back of his bike impacted into the back of his head, and they're the teeth of the person behind him. They got stuck into his head. And then when you think of trauma, you also think of surgery, because, as I say, those teeth were removed, and therefore, even with the treatment of the trauma, you have quite significant brain injury. And you can see the penumbra there, and the secondary injury to the brain. That was the focus of our talk. Yeah. So traumatic CT scans. Were you here for that one?
I saw, yeah.
You saw them? Okay, so you know the answers. All right. So the single highest risk factor for a traumatic brain injury is being male. You're 2 times more likely to have a traumatic brain injury if you're a man than a woman up until the 7th decade of your life. And when you think about a traumatic brain injury, I think it's really important. What trauma is the rapid dissipation of energy into a body tissue. So as with any trauma and trauma to the head, the place at which that energy is dispersed is the place at which has received the injury. So for this one, for example, this is a lenticulate extradural. Okay, so that's typically an arterial, so it's one of the meningeal arteries that may have been ruptured. Often it's blunt force injury. They often have underlying fractures of the skull because they're quite high impact injuries. Classically, they have a period of lucidity before the hematoma accumulates, and then they reduce their GCS, although that's only true in about 20% of people. So it's important, first of all, to look at your bone views, see if you've got skull fracture, see if there's an indication for pneumovax. They respond very well to decompression, and more often than not, these patients will be immediately accepted for surgery. So drainage is probably the single best thing. They have quite good outcomes if they're rapidly drained. By contrast, you have a subdural, which is classically a venous injury of one of the bridging veins. They can be, they're generally more indolent in their presentation, with a headache. They commonly have seizures. They can be either acute, where they formed in less than 3 days, subacute up to 7 days, or chronic, which is over 7 days, over 2 weeks. They less commonly drain these ones because it will just encourage further bleeding more often than not. So they will typically they will look at the injury. As with tumours, you look at the injury itself, but then you look at the effect it has on the surrounding tissues. So an indication for drainage may include a midline shift of 1 centimetre or more, or very strong clinical signs. And as you see on the right, there's a patient who suffered an acute on chronic subdural, and they're often more likely to be managed conservatively. You have subarachnoids. So this would be classically typical of a traumatic subarachnoid. As you see, traumatic subarachnoids will generally be in the frontal area, frontal temporal area. They'll be in more peripheral areas, and often sometimes in the posterior fossa as well. Again, these are areas that are closely adherent to the skull vault, and so therefore more susceptible to injury. You can also get these from non-traumatic reasons, as you all know. Or you have your intraparenchymal bleeds or contusions. This is not a good example of a traumatic contusion because you see the distribution. It's in the midbrain. It's more likely to have been a hypertensive bleed, and if it was a Traumatic bleed, these are typically from impact and deceleration injuries. If they're more than 50 mils, again, because they've rapidly formed, they can respond quite well to drainage. And then two other areas of trauma that I've not included on the scan would be diffuse axonal injury, of which you might only 70% of them may show nothing on their first CT scan, and they're often by clinical suspicion where your neurological signs are out of keeping with your clinical assessment at your investigations. You may see punctate areas of hemorrhage, but it's often the axons that are damaged. The patients typically have more of a sympathetic surge, so they will have high temperatures, high blood pressures, reduced GCS, which is not associated with cerebral edema, although they can get cerebral edema. And the other area of CT where you have a CT normal patient with a traumatic injury would be the central venous thromboses. So you can sometimes see an empty delta sign on the CT scan, but more often than not, it's clinical suspicion. So you may see the hemorrhages in the areas of drainage, or you may have to do a dedicated scan to look for that. Again, it's something to consider. Goals of management. This is as far as we got. So we got quite a long and good answer here about goals of management. I think it's important to break it down. The primary injury, for most patients, there isn't a lot you can do. It's happened. The injury is done. And so the primary decompression does happen. So, for example, in hematomas more than 50 mils, number needed to treat is 2 for a good result in those, or 6 for an outcome without disability. And then most of what we can do in anaesthetics and critical care is to minimize the risk of secondary injury. And I think it's important to understand how that injury might form in how we minimize the risk of secondary injury. There will be inevitable responses of the brain to injury. So you've got to think the brain doesn't store oxygen and the brain doesn't store glucose. So you need to make sure that you're maintaining a good supply of glucose and oxygen. That will involve having it in the bloodstream in the first place. So intubation and ventilation, as you said, maintaining, because they may not be self-ventilating effectively enough to get the oxygen in. It also involves maintaining a perfusion of the brain tissues, the injured brain tissues. And that can be intrinsic and extrinsic. So you will have reasons within the brain why the brain is not perfusing areas of tissue. And there are things you can do with that, which you can talk about. And then there are extrinsic reasons. So there are reasons without the brain. So low blood pressures, for example, or cardiovascular collapse, or pulmonary edema. So neurogenic pulmonary edema would be another cause. And they generally follow a journey of, so you have day 0 where you might have hypoperfusion is the main mechanism of injury. And that's, as we will talk about a little bit there, you lose your auto-regulation and you lose your perfusion. Then you have, from about day 3, you have a period of hyperemia, and that's related to vasogenic edema, cytotoxic edema, inflammation, loss of the blood-brain barrier, leukocyte plugging, free radicals within the brain, and there are things we can do about that. And that's often the case more with those with focal brain injury, so those with areas of penumbra which have changed. And then from about 1 week, then you start to worry about vasospasm, which is less of an issue for most. But then again, it's a loss of neural regulation. So if we break that down to how we would maintain that, so cerebral perfusion. So CPP is a cerebral perfusion pressure. There's a diagram there. So the pressure that you go in and the pressure that comes out. And the pressure that goes in minus the pressure that comes out will tell you how much pressure is delivered within the brain, how much is dissipated within the brain. It can be the ICP, which is the thing you take away. If the ICP is higher than the CVP, so whichever is the highest, really, you take it away. And typically the ICP should be about 10. So you can go map. So if you want a cerebral perfusion pressure of 60, you could, in the initial phase target a map of 70, and that will assume a reasonable cerebral perfusion pressure. The intrinsic mechanisms, so they're the extrinsic mechanisms. The intrinsic mechanisms involve flow metabolism coupling. What does that mean?
Increasing the need for glucose metabolism actually inside the brain actually. So we need to decrease the metabolic rate of oxygen of the brain to decrease the consumption of the glucose around that.
So that's possibly so that would be that's very true. Yeah. So that's more cerebral metabolic rate for oxygenation. So looking at sedation to reduce the sedation, also reducing temperature and things to reduce the metabolic demand of the brain. So that's true. When I was talking about flow metabolism coupling in this sense, I'm talking about how the brain auto-regulates. So there are myogenic mechanisms, there are physiological chemical mechanisms. So myogenic would be the direct response of the brain to the pressure. So this is a common graph. So this is cerebral blood flow according to the pressure that's supplied to the brain. And as you can see, the two dotted lines will represent 50 millimeters of mercury and 150 millimeters of mercury. You can see that the brain, when it's functioning properly, manages the blood flow quite well and maintains a steady blood flow regardless of the cerebral perfusion pressure. And that's a myogenic response to supply the brain, although that can be disturbed. First of all, neonates have a left shift, hypertensives have a right shift, and people with trauma or subarachnoid hemorrhage may lose that connection altogether. And so you have to be more careful about how you manage your cerebral perfusion pressure. Then you have metabolic demands. So this is another famous graph. So you're looking at cerebral blood flow according to how much CO2 and oxygen is in the blood that reaches the brain. And as you can see on this graph, that within a normal physiological range, oxygen itself is maintained at a pretty steady state. So cerebral blood flow doesn't really change according to oxygen, except when you become hypoxic, when you suddenly have a rapid increase in cerebral blood flow, and that inflection point is about 8 kilopascals. With CO2, you see a slightly more of a direct relationship. So you can see there's an aggressive change in cerebral perfusion pressure according to CO2. So an increase in CO2 of about 0.1 might increase blood flow to the brain by about 1 to 2 mils per 100 grams. So the CO2 control, as you mentioned, is quite important, because if your CO2 is high, you will get higher you will get higher blood flow, and that can be in local areas or that can be disparate. And if your CO2 is low, you will have a reduced blood supply to the brain. There's Robin Hood syndrome, whereby if you overcorrect your CO2, you will just, it's like a Steele syndrome, like a coronary Steele syndrome, whereby you can overcorrect that and direct blood inappropriately according to that. So the advice would be to aim between 4 and 11, which is that normal range, where it's then between 4 and 4.5 is ideal. Chemicals and drugs have an effect on cerebral perfusion pressure.
I've already disturbed the blood-brain barrier already.
Yeah, so you have a disturbed blood-brain barrier. Most drugs we give as anaesthetist will reduce your mean arterial pressure, so that will reduce your cerebral perfusion pressure. Many drugs neurovasodilate, so all your volatiles will cause vasodilatation of the cerebral veins, though opiates have very little effect on cerebral circulation. So that's often, we give very opiate heavy anesthetics and
so that it has also anti-epileptic effects.
So midazolam does have an anti-epileptic effect, although it doesn't cause burst suppression. So there's a limit to how much it's gonna, there's a limit to how much it's going to reduce your cerebral metabolic rate of oxygenation. So anybody want? Oh, I've already put it up there now. So Monro-Kelly doctrine, we've all covered it in medical school. The brain, the skull is a closed vault, and therefore the combined volume of all the components are constant. So if one of those is displaced, there will be an accommodation or there will be damage to brain tissue. In stage 1, this is anyone with an ICP of below 20 generally, you can see that the brain can auto-regulate that. So often it's the venous circulation reduces in volume, and the CSF can reduce in volume, followed by the arterial circulation reducing volume to accommodate that. In stage 2, they call this between stage 2 and 3. This is areas of focal areas of ischemia, where the pressure is becoming too much for the elastance of the brain, and so you start to see damage to the brain. And then when you get to stage 3, you can have quite aggressive changes in the intracranial pressure in response to changes in intracranial volume. So what's the signs of intracranial high? What's the signs of a high blood pressure in the brain? Headache. Headache. So that's a chronic sign. So you can get headaches. Yeah, you can get headaches. That's typically not what we see in A&E though. Papilledema. Yeah. If we look, don't dilate the pupils there. Seizure. It's less common to see seizures though, isn't it?
It's rare. You get Cushing's reflex before that.
Cushing's reflex.
Hypertension, bradycardia.
So reduced GCS would be the number one thing I'd say. Okay. Eye signs. So this is because the cranial nerve 3 runs along the base of the brain, and so it can press against the gleno something ligament. So you can often see cranial nerve 3 signs, which are ptosis, pupillary changes, loss of the third ventricle, which I couldn't find online. So this is actually my. Let's see if I can get that. This is actually when my dad had a skiing accident this year. This is his CT. So you see that you've got your 2 lateral ventricles, and you've got top of your spinal column, and then this is your third ventricle here, and you can see it forms a smiley face. So that's a normal brain, particularly if you're older. You've got more room around it. Let's see if they've lost connection again. So you could say loss of third ventricle is a very subtle sign so loss of this is a very subtle sign of increased intracranial pressure, and then it can progress to herniation. So this is where you get your Cushing's responses, and I think the herniation depends on the site of the herniation. So you can have tonsillar herniation where the brain is pushing down into the foramen magnum, and they're the ones that will classically get you Cushing's sign of hypertension and bradycardia. Temporal herniation under the tentorium cerebelli, so that the tentorium cerebelli sits here, and so if you push down on there, you're going to push down your cranial nerve roots, and again they're going to typically get your cranial nerve 3 signs, which is your dilated pupils. And subfalcine, which is across the falx cerebri, so this is a lateral shift under the falx cerebri, and they're often less common because they're often related to focal brain injuries, but you can often see stroke-like symptoms from those. So they may be limb weakness, aphasias, and things like that. So it's getting quite repetitive. So how would you approach them? AB, we've established that an oxygen above 12 is good. CO2 between 4 and 4.5. If you go too low, you don't deliver any benefit because you lose perfusion to the brain. If you go too high, you just cause vasodilatation in areas that possibly don't need it and cause edema. So we've got that graph there. Circulation. So anything that focuses on cerebral perfusion pressure. Okay, and again in C, a common thing that we forget to do is to correct the coagulopathies, particularly subdurals, if they come in and we need to check what they're on and whether they need anything to correct that coagulopathy. And so again, I would recommend maintaining a map of about 70, because then you're assuming, because you don't know what the ICP is, but then you're assuming you're giving yourself a safe zone. Disability, glucose is very important. It's often a common thing that people miss when they're assessing somebody with reduced GCS is to check the glucose. And some guidelines would recommend just giving them glucose just on spec, just to make sure it's not that, but also to maintain a reasonable supply of glucose, because again, the brain can't cope for long without a supply of energy. Check your alcohol levels. That's helpful for 2 reasons. Again, that's another reason why it's a consideration on your neurological examination. It's also a reason why you might have a high already have a high osmolality in the blood again. So osmotherapy would be less likely to be helpful in somebody with an osmolality of 320 if somebody's alcohol intoxicated. Treat seizures if they're happening, because again, that's the cerebral rate for oxygenation, cerebral metabolic rate for oxygenation, and a comprehensive neurological examination. I think the important thing to say about that is there's a lot of intra-observer variation. So I think it's really important not just to document the GCS, it's to document how it breaks down. What does that mean? I've done this examination. At what time did I do it? So before I've done a CT scan, I've checked my pupils. I've looked for lateralizing signs in the limbs if you can, and I've documented the GCS, and I know what the M score is M3 because they've suffered pain. They've moved, they've flexed their arm when I did a supraorbital pressure, because that often is helpful when you're doing serial assessments to know actually what does the neurological examination mean, and then everything else. So at that point is when you think about imaging and onward referral. Prevention of seizures, again, is a bit more of a considered thing, and often you might need the neurosurgeon to advise on that. So often they'll ask for subdurals, compressed head injuries. There's some evidence of benefit, but again, you're not going to harm necessarily too much from giving it, but it's not always the advice to give antiepileptics. Antibiotics and pneumovax for those with any injury that's compromised the skull vault, and a urinary catheter, which is one of the commonest things you see on receiving a neuro patient from another centre, is that they've forgot to do that, and then they've given mannitol and they've got a bladder with 2 litres in it. So it's quite helpful. It's quite helpful for monitoring, as well as it's a sensible thing to do that often gets missed. And so what happens if they've been accepted to a tertiary centre, or we have to take them to our own unit? We can think of the general measures, which are the things we have within the power of our abilities to deliver, and then there's other interventions that could only really happen in a specialist centre. So oxygenate, ventilate, maintain a blood pressure. Your transfusion trigger is slightly higher for those with traumatic brain injuries. And in a tertiary centre, you could consider ICP monitoring with a bolt, and you can target an ICP of less than 20 or a cerebral perfusion pressure of more than 60. That's not something we can necessarily do here. Again, I can't reinforce this enough. Regular explicit neurobs are very helpful. And I think, again, pupillary responses can be quite difficult and subjective to do. There is a pupillometer you can get which actually measures the pupillary response and tells you, but I don't think it's in common use. In the specialist centres, they could do continuous EEG monitors if they're concerned about ongoing seizure activity, or if they just want to, if they are concerned about cerebral edema and they just want to reduce the cerebral metabolic rate as much as possible. Maintain a temperature below 37. They often have high temperatures. They often have low sodiums. This can be related to cerebral salt wasting, which is thought to be an ADH release, and it's associated with a high urine output, with a high urine sodium, and they are dehydrated, which is often, you will see SIADH, they get starved of their water. So therefore, if you're cerebral salt wasting, you will lose free water. So you need to provide them with some replacement. They can sometimes get fludrocortisone for that. Maintain a normal glucose, and generally you don't anticoagulate brain injury except when you're advised to do so. They are at high risk of thrombotic complications, but on the risk balance they don't.
2 weeks.
2 weeks, yeah. You worked at Nottingham, have you?
Yeah.
Yeah.
Once, twice, yeah.
Yeah. So 2 weeks is often the standard advice that they give. And again, EVDs and decompressions. And the thing that's I've not mentioned on there, which you will know if you work in Nottingham, is the other main therapy that's provided there is repeated CT scans all day and all night. So if anything changes, CT scan. So they do a lot of CTs there. And that's all I've got to talk about, really. So it's quite general. See if I can get these slides showing. If I can. So see everybody. Did you manage to hear that at the Royal then? Deepak, do you have your hand up?
Yes, we had. Thank you very much. Thanks.
Is there anything you want to ask or say about that?
Do we give TXA to any of these patients?
So the CRASH 2, I think it's a CRASH 2 trial. Your CRASH 2 trial looked at tranexamic acid. I think my experience is that the CRASH 2 trial didn't show statistical benefit, if I remember rightly. So I think it's often not automatically given, although I don't think anyone would object to it being given. Again, the CRASH 1 trial was steroids, wasn't it? CRASH 2 was TXA, and I think CRASH 3 was TXA as well. So I don't think it's routinely done, and correct me if I'm wrong. No.
Against it, I can't remember why. I think like the side effects.
Yeah. So yeah, so there is some concern about thrombolytic side effects. Again, high doses of TXA can cause seizures as well.
That's the other thing, in the brain.
So I don't think it's routinely done, but I don't think you would be excessively criticised for doing that. But again, if you have a clear mechanical cause of blood being lost, so often is a mechanical solution to that, and it's naturally tamponaded if it's not in Nottingham, except in compressed fractures. So I don't know how much it would benefit. It's not the first thing that people think about now.
Thank you.
You guys will see a lot more of this than we do at the Royal.
I was just going to look at a paper and talk to you about it, about intraventricular lavage versus external ventricular drainage for the treatment of intraventricular hemorrhage. So obviously it's not something we do here because it's not a neuro centre, but it is interesting, and it's something that you often come across in your training at some point. And there's a couple of key features in this paper I think are worth talking about. I wonder if I can just get that out of the way for you, just to make that slightly easier to see. Is that better? That's better, isn't it? Good. So they had a key question, like most things do. There we are. Is ventricular lavage a safe and effective treatment for intraventricular hemorrhage compared with passive drainage? So passive drainage is an external ventricular device. So we'll go through a couple of key things. Maybe this starts to work. Good. So a very, very quick overview, because we're not here to talk about intraventricular hemorrhage. I'm sure Dr. Murphy's covered a lot of intracranial pathology already. So it is a serious hemorrhagic stroke. It's bleeding into the ventricles. And it generally comes with a very poor prognosis in adults, especially the higher down the severity line you go. Treatment is generally just supportive, so supportive intensive care, as we've talked about, in terms of normalising everything you can normalise and optimising everything you can optimise. And then CSF drainage is a secondary resort, so sticking an external ventricular drain in to passively drain the haematoma and alleviate any intracranial pressure caused by hydrocephalus or CSF outflow obstruction. So this is where I hope that my little video works. So the company that sponsored this trial are IRA. They're a Swedish company, and they made something called IRAflow, which is an intraventricular lavage device. And I thought it was just easier to watch hopefully watch their little video on it. Hopefully that plays. And if it doesn't, I can just talk about it, but I don't think. No good. That's fine. So what it is essentially is it's like any external ventricular drain. You insert it into the ventricle via the skull, via the cranium, and rather than it just passively draining fluid, which is normally connected to some form of manometer to measure the pressure, it actively lavages, so it'll wash in some physiological saline and aspirate every so often. And the idea is that the quicker you can remove the hematoma from the ventricles, the quicker you remove that inflammatory response, that neurotoxicity caused by the breakdown of blood products. And then that leads to a quicker recovery, because you've got a shorter ITU time, you've got a shorter time needed intervention, i.e. drainage, and fewer complications such as infection, CF infection, ventriculitis, and a reduction in things like catheter occlusion, because you're lavaging it the whole time, you're washing it through. That's the theory anyway. And that's basically what I've just talked about. So their aims, they had a couple of main aims, as we often do. So they wanted to first of all assess the safety of the device they've just created, and whether it truly does at least show non-inferiority, or at best show some form of superiority to the current standard. So it's for Dr. Paul's benefit, just looking at external ventricular drainage versus intraventricular lavage for the treatment of intraventricular hemorrhage. That's where we got to. So the study, it's a single blinded study. It's very difficult to blind the physicians in this. And the statisticians and the patients were obviously blinded, although I think the patients were normally sedated in ITU, so they're not really that active a participant in the first place. It was a phase 2 randomized clinical trial, so it's testing experimental intervention, and obviously we're testing against the current gold standard, which is external ventricular drainage. And this was a prospective study done in Denmark across 2 sites. It's initially meant to be 3, but we'll find out why it was only done in 2 sites in the coming up slides. So participants, so everything has a inclusion and exclusion criteria. So adults essentially were included with either a primary or a secondary intraventricular hemorrhage, and had an indication for CSF drainage. I met the criteria for that intervention in the first place. Patients had a Grieve score of greater than 2. So this is a measurement of essentially how much blood there is in the ventricles and in the ventricular system in the brain. And basically, the higher the number, the worse it is. And obviously, it needs to be either having a deteriorating GCS or being sedated already on intensive care. As standard things go, they excluded things like pregnant or breastfeeding ladies and people who already had fixed or dilated pupils. I think that's a rather terminal event. So they were hoping to get about 58 patients in this to give them a 80% power in the study. And the patients they did manage to gather, the demographic is relatively comparable. So the 2 groups, they look relatively balanced, as you can see there. Now, you might notice something at the top of this that's a bit alarming, which is that the numbers in each group are rather small. And we'll come on to why that is a bit later. But essentially, this just shows that the groups are relatively even in terms of their spread of population. And I'll talk about exactly why those numbers are so small in a minute, but I'm sure you could probably guess why we'd stop something early. The other thing I was going to point out was the fact that the GCS, the average GCS of these patients is actually quite low, as you might expect. They need a drain inserted, and also their Grieve score is quite high, and all these are quite good markers of a severe incidence of intraventricular hemorrhage, which might become important later on. Right, where did I get to? Okay, so the 2 interventions. So I've talked about. So the standards, the control or usual therapy is to insert an external ventricular drain, which is about 10 French. It's done with a minimally invasive technique, done through the scalp and into the skull vault. The intervention is a slightly smaller drain. It's a 9 French rather than 10 French, and it's this IRA flow thing, which unfortunately you can't see, but there is a minute-long YouTube video you can Google if you're that interested. But I think you can probably imagine what it looks like. It's essentially a catheter that can both wash things in and aspirate things out. The ventricle is placed in the contralateral side to the most affected ventricle. Interestingly, if there was evidence of foramen of Monroe obstruction, an external ventricular drain was placed on the contralateral side either way. So if they were in the intervention arm and they had outflow obstruction, they still got an EVD anyway, which might cause some kind of problem later on. Who knows? We'll find out. So safety outcomes. So the primary outcome they're looking at was the rate of catheter occlusion, and the secondary ones were all to do with kind of efficacy, so to speak. So procedure time, how long does it take to put one in, the length of stay in ITU, which is obviously a good thing if we could reduce that, along with things like duration of intervention therapy, 30-day mortality, as we love to do in these sorts of studies, and then the number of catheter interventions that we needed to do in the first place. So the null hypothesis was intraventricular lavage has no effect on the catheter occlusion rate compared with the standard passive external ventricular device. So let's look at those all-important results. I'm sure you're gunning to see them. So the reason why there's so few participants in this study, as you might see from the first column, is the fact that there were so many side effects. Adverse. So SAE stands for serious adverse effect. Serious adverse effect or adverse event was classed as death, CNS infection, intracranial hemorrhage post inclusion in the study, i.e. we think it's something associated with a catheter or something we've done. Catheter misplacement and occlusion of the catheter requiring surgical intervention or medical management, so something like alteplase. And as you can see, the intervention group is significantly higher than it is in the control group. Now, the p-value is slightly different. So because this is an experimental trial, and this is the interim data analysis, they had a slightly higher p-value cutoff compared to what we're used to. So rather than the less than 0.05, they had a less than 0.2. So if there was a leniency towards demonstrating harm, they could stop the trial early in one side or the other. And as you can see, because we've got a value of 0.04 in the risk side of things in some of those and 0.01, this trial was stopped early because of that reason. So it's done on safety grounds. And we could talk about that a little bit in a second. I'm just going to highlight some other things, which although there's a lot of non-significant data, there are a couple of things that do lean towards something that might be of use. So the number of catheter occlusions is actually higher in the intervention group, and the procedure time is significantly longer in the intervention group as well. My initial thought when I see a procedure time is longer in a new and a novel treatment is that people aren't familiar with it, and that might well be the case. But they were adamant to state that these clinicians had extensive training on these devices and were hot on all the techniques, yada yada yada.
Is it not? It's very likely to be if they're targeting the unaffected ventricle, they're trying to get it into a tiny ventricle, aren't they?
Well, yeah, that's
The easiest thing to do with an EVD, because it's so massive. You just stick a hole and you've got a massively dilated
exactly.
ventricle. Whereas actually, if they're trying to put it in the normal side, that's already probably compressed. So, I think it'd be harder to find the ventricle, wouldn't it?
Yeah, I would agree. But also the actual surgical technique for inserting this is some kind of retrograde tunneling system rather than just a straightforward stick it through the skull like you do with an EVD and suture it in. So the actual surgical technique is longer and technically more challenging. So I actually start to think that number might be significant and actually a true representation of the difficulty of the procedure. What else is there to note on this? So the number of interventions, i.e. how many times I had to play with the catheter for whatever reason, whether it wasn't working or it was blocked, is significantly higher as well. The things to note, so obviously the risk of serious adverse events is so much higher in one group than another. I've actually looked at the raw data and it is pretty damning for the interventional catheter side of things. So they nearly all of them got drain occlusions. A lot of them got ventriculitis, and a number of them were actually irrigating the brain parenchyma rather than the ventricle itself. These were all pretty significant events, obviously. In the control group, the adverse events were, there was one, I think, catheter occlusion and maybe one episode of ventriculitis. But actually, on the reflection of it, the patients that died or end up dying from the control group were probably going to die anyway, just looking at the raw data. So I don't think you can blame the control on that respect. So I'm starting to think, although this trial stopped early, it was probably stopped early for a good reason. Anything else to highlight on these numbers? I don't think so. Let's have a look if I've clicked anymore.
So part of me thinks, looking at those numbers, how did they get ethical approval for the study? Because they should have. You usually do a
good question.
They calculate how many patients they need and stuff, and they would have had to do a proof of concept.
So there was
it's such a massive difference, isn't it?
Yeah. So there is some evidence, some very speculative evidence, and a couple of case reports of people using intraventricular lavage with demonstrated benefit, obviously in not controlled settings, not randomized settings. So there's some evidence for it out there in the ether, and this might be related to the device rather than the technique. So that's something else they talk about looking at in the future. So maybe it's the device they've used rather than the technique itself, because there's still quite a lot of favorability towards this technique in what the authors have said, and also what other authors have said as well. So things to explain the results. So the small balloon, the 9 French over the 10 French, might lead to a higher risk of occlusion rate. The lack of antimicrobial coating on the catheter might lead to a higher infection rate in ventriculitis. And they thought there might be caused some damage from the constant exchange of saline and CSF, as well as negative pressure in the system might have led to unnecessary damage in the ventricular system as well. And finally, we talked about the unfamiliarity with the kit. And I think, yeah, like I said, whether there is an element of new kit means things take longer, but also looking at the raw stuff and the actual surgical techniques to insert it, it does seem a lot more faffy and a lot more complicated. And with extra steps becomes extra risk of error, doesn't it? So I'm inclined to give that less of a leniency. So like all paper, we must highlight the limitations of it. And I think we've talked about a lot of them already, but other things to just highlight for the sake of academia is that there's lack of an inability to double blind the study, because obviously the surgical intervention is different. We have altered the p-value, so you could argue that the risk of type 1 error is higher, as well as, like I said, the raw data suggests that these patients are very sick in the first place, and perhaps they weren't the ideal candidate for having such an intervention. But then again, it's a bit like it's a bit like a catch-22. If you're not that sick, you don't end up with an EVD in the first place, and if you are that sick, you by definition fall into a severe category, and then you end up with an intervention. So it's not always easy to give that a justification. And like I said, that this is a novel treatment. Quirks of the system or quirks of a novel system might cause problems in terms of staffing and intensive care in other places where they're not familiar with it. And like I said, when you've got one intervention that you're looking to explore and then you've stuck in the control intervention anyway, I'm not sure how well that or how badly that affects your data. In reality, that was only done in one patient. Actually, they only had one patient and have an EVD and the intraventricular lavage, and that patient died anyway. So I don't know if we can really glean much from that at this point. So my final thoughts are that I think it was, although it was relatively well constructed as a trial, they were rightly hindered in their results by stopping the trial early, and I think that was probably the correct thing to do. So having looked at the raw data and having looked at their results, I think there's a theoretical benefit, isn't there, of earlier breakdown of hematoma and clot removal and kind of restoring normality to the ventricular system, and perhaps that can be done by a more superior intraventricular lavage device, but the one they have used in this particular study I don't think will be hitting our shelves anytime soon. But they are again keen to go and explore this in further detail, so I will leave that to them. Interestingly, the study was funded by the company that makes the device itself, which I think is quite ironic. They've just demonstrated their product is very bad, but at least I think we can take their results more reliably, if anything. So I think we'll leave it there. If you've got any questions about anything, fire away. I'll do my best to answer them as well as I can.
Thank you. So when you so this is to treat hydrocephalus, isn't it?
Essentially, yeah.
So when you got blood in your brain, the blood blocks the Sylvian aqueduct, the FOM, and that blockage causes a backup of CSF, which causes hydrocephalus, which reduces GCS and puts pressure on the brain.
Yeah.
And so when you get hydrocephalus, it's like Laplace law, isn't it? So the bigger your ventricles get, the more compliant they become, and the harder it is for them to get smaller. So when you've got patients who have got hydrocephalus, that's our randomization.
Yeah.
So then you're putting something into the non-dilated ventricle and trying to put fluid into that with the hope that that's going to pass down into the spinal column to unblock it.
And expedite the kind of clearance and kind of
So what's to stop that going into the other lateral ventricle?
Well, exactly. I think that's
so. Because wouldn't it not bias into that ventricle if you've got a more compliant ventricle? Because the bigger it is, the more compliant it becomes, doesn't it?
Well, yeah, that makes sense, doesn't it? Perhaps maybe the plan would have been slightly better if they had gone into like you said, the larger ventricle. It's easier to do some surgical techniques.
Because if you had a blood clot somewhere else, you wouldn't lavage it with saline, would you?
No, exactly. Well, their thought is that the kind of natural breakdown through the CSF is what's promoting absorption, but I couldn't find much physiological evidence of that. I think they were more looking at that if a theoretical of a higher exchange of CSF volume would increase the clearance just through a natural maintenance of diffusion gradient, but I don't think that's a fantastic.
Because another way to do it would be a spinal drain, wouldn't it?
Well, yeah, I suppose, but and then if you got a spinal drain, are you already distal to the problem?
You are, but they're going to increase the pressure on the other side. Is that not what they're doing?
I think that so yeah. So I think that the idea was that if they're washing and aspirating, it's kind of like a pull and push kind of situation. So you can maintain a normal pressure whilst
like a blocked heart line.
Exactly. Well, we say you maintain a normal pressure whilst maintaining maintain a normal pressure whilst exchanging the CSF fluid in that ventricle. Is the theory, but again, it's not something I would have dreamt up overnight, I don't think, and I've not seen it been talked about when I was doing neuro stuff. So I doubt they're. I think I spoke to a neurosurgeon about this, and I spoke. My wife works in neurosurgery as well, and I think her opinion was that if you've got to that point, they're all going to struggle anyway. So what's this is kind of drops in the ocean, to be honest. their recovery scores are not all fantastic anyway.
Thank you very much.
Pleasure.
I don't know if the Royal can still hear us.
I hope you can, but if not, I apologise.